Hello and welcome to Westwind, an audio podcast about cancer, technology in medicine, and policy issues. I'm host and medical oncologist Dr. Jack West from the City of Hope Comprehensive Cancer Center in the Los Angeles area. You can find Westwind material at BeaconMedIC, one word.com, at iTunes, or just about anywhere you get podcast content. I would just ask that you show your interest and support by subscribing, commenting, sharing by telling friends and colleagues in person and on social media, and rating it however you feel is appropriate. You can also share your ideas and opinions by emailing us at westwindpodcast@gmail.com. This is the second half of our discussion with Dr. Nargis Duma, thoracic oncologist, with a particular focus as well on gender bias issues in this episode of Westwind. Talk about the Latinas in Medicine initiative that you have, I believe, been a leading part of.
There's like our baby. So I remember being in the elliptical at the gym and having an idea. It's like we should create a Twitter community for other Latinas because we're only 2% of physicians in the US. So isolation is so common and we don't look like people think doctors should look like. So I reached out to other two friends and we created the community overnight. And it's a Twitter community to amplify and to connect Latinas in medicine, to share our experiences, to make sure you don't feel like you have to fit in. Because that's one of my feelings during residency, that I should be somebody else because there was nobody else that sounded or looked like me. So we created the community and now friendships have been developed, we and the group. We have a book club and we have mini interviews where we interview Latinas from different parts of healthcare. And it has served as a motivation for younger Latinas who are thinking in becoming PhDs or physicians. And soon we're going to launch our first study to understand the challenges that Latinas face during training, in addition to create a national registry, which it will help to connect and to produce in the future a mentoring program of younger Latinas with older Latinas or in different phases of their career. So the Latinas in Medicine was a dream that became true overnight. And we're very excited. These little things, we're getting even merchandise coming soon. So it has been growing over the last 6 months.
That's great. And one thing that Esther Chu, a great ER physician in Portland, has talked about is the challenge as an Asian woman in medicine in the ER of being confused for somebody who isn't the doctor, a nurse, or some other support. And also just sometimes outright racism of people saying, I don't want any Asian or a woman caring for me. Did you have any of those experiences with patients?
I think many women have similar experiences, and I had many. The one that I always makes reference to, Jack, is I'm wearing a black suit. So a suit. Jack at Mayo Clinic, we wear suits every day. We my stethoscope and my pager and my badge. And unfortunately, I was confused by somebody from the janitorial services, which is a very good job and a decent job. But there's a lot of Latinas that work in janitorial services. So I was easily confused by this instead of like, oh, she can be somebody else. And I have heard so many stories about so many young Latinas being confused as a social worker, as a translator. The translator, I would say, is the number one. I have entered the room and say, hi, I'm Dr. Duma. One of the things about marrying my husband is he has an easy last name. And then I leave the room and then the nurse comes in and the patient is, oh yeah, the translator was just here. And this is in the same language, Jack. We are speaking Spanish. So it is a thing.
Now, what was your maiden name and did you consider keeping that or had you decided to take on your husband's name? Was that always your consideration?
So my maiden name was Perez Flores. So my mom and my dad's. So the option was to be Dr. Perez Flores Duma I'll be Dr. Duma. So for practicality purposes, I decided just to go by Dr. Duma.
Okay.
So I think it made it easier for my patients too, because sometimes they didn't know if it was Dr. Perez or Dr. Flores or Dr. Perez Flores or Flores Perez. And I think my husband liked it too, that we're one family. It's a cultural thing. We don't change our names back home.
Ah.
Yeah.
Did your family have any issue with the name change?
I think after I became an internist, my father just lost hope. So he was fine with that.
He gave up on you after you were no longer a surgeon.
He was like, it's fine, whatever you want.
Okay. How long have you been married?
Been married for 8 years. We got married in Seattle in April. And having an April wedding in Seattle, people told me it was tricky because there were high chances of raining, but it didn't.
No, that's great. It can be beautiful there. Now, let's switch gears to another big issue of yours, which is gender bias and inequality. And one of the real issues is the difficulty of being able to maintain momentum in your career while having kids. Have you felt difficulty in finding a time to have children? I know you've mentioned fertility treatments, and if you can speak to your thoughts on when or if to have children and the challenges and potential compromises of that with how you're perceived at work and how your opportunities will present themselves for your career.
I think that the issue of children for young professionals can be divided in several parts. The first thing, just to be linked to the Latinas in medicine, is that being Latinas, the expectation is that you get married in a maximum of 1 year, you should have a kid. So that's an extra challenge that many Latinas and people from other cultures experience. It's a social expectation that reproduction is a priority, which it can be for some people, and we respect that. But that was the first obstacle I encountered, was like, okay, I'm married, and then culturally, my entire family was expecting me to have a kid. And many Latinas have shared that with us through the Latinas in medicine community, how their families feel like they're a failure despite being physicians just because they don't have a kid. And as women, having children shouldn't define who we are. It's a superpower that we have. I always joke saying, like, tell me one thing women can do that men can't. And I would tell you one. So that was the first challenge. And the second challenge, when is the right time? And I have experienced recommendation open doors and recommendations close doors. So the recommendations open doors is what people say at conferences. Oh, you should have kids when you can. That is never the right moment. But when those doors close, then you learn about the baby tax. And the baby tax is the tax that many women in many careers have to face when they decide to have children. This is the only tax that you start paying even before you even move or you have the children. So when you start planning to have children, sometimes, and this has been reported in other studies outside of medicine, women are less likely to be given opportunities because she's planning to have a kid, or women are removed from committees because she's planning to have a kid. And sometimes ourselves also say yes to some things and say no to other opportunities just because we're planning to have a kid. So we leave before we really leave. And the other part of the baby tax is the fear that you will take that time off and then you will lose in your career. So when those doors are closed, I have been given the recommendation, and I would say 3 weeks ago, I was given the recommendation to hold on the baby because right now I'm doing so good. And it is funny because you don't know what to listen to. My mother also waited to have children because of her career. And when I talk to her, she always says, I wish I had them sooner. So you don't know what is the right answer to this. And then you wait, you do residency, then you do fellowship, and we get older. And that's a blessing as an oncologist. But you get older and your eggs get older too. Unfortunately, we are born with all other eggs, and they get old as we get old. And the issue of fertility is not spoken about. This recently, Dr. Salas from from Washington University, talked about it, about how she spent her fertility years training. And that affects many women, Jack. And I think we need to talk more about it, because then you're expected to reproduce, but then you feel let down when it doesn't happen because you're in your 30s and it's harder. It's biologically harder. So I hope that our conversation today, the research that's being done, including Dr. Marshall from Mayo Clinic, this conversation becomes more common, and that our trainees don't feel bad about having fertility issues, because it's a common thing. We are getting older. And as people say, you should get pregnant when you're 18 and 21. Back then, we're still like an undergrad. So thank you for asking, because it's so important to talk about that.
Now, I know there is a Women in Medicine Facebook group. I believe it's the Wolfpack, and I'm not privy to the discussions, but I've had several of my colleagues talk about how valuable that is, including talking about balancing motherhood and the various responsibilities and obligations of being a parent with career opportunities. Do you have much support from that channel? And is there any opportunity there to delve into fertility questions?
Well, I'm going to explain a little bit what the Wolfpack is. So, the Wolfpack is a secret double coded Facebook group of women in hematology and oncology. So, surgeons, medical oncologists, pathologists, radiation oncologists. It was founded by Dr. Cole, Dr. Graff, and a few other very successful women physicians. I was added to this group by Dr. Karen Wingfold when I was a third year resident. This group has been an amazing resource for me. First, because my gender bias abstract for ASCO started there by the mentoring I received in that group, and many of the co-authors are Wolfpack members. So in that group, we're able to discuss challenges like fertility, and you feel that extra layer of support. And also, you learn from women that are a little bit ahead of you that some of the things that you're experiencing today, it is still normal. Like even people that has been in their career for 10 years, they still have imposter syndrome. That's like the cold. You cannot get rid of completely of it. So the Wolfpack is a marvelous group, and they have some literature that was published in the Journal of Oncology Practice about the benefits of having the group.
And there's been more research coming out about gender disparities in clinical trial leadership and talking about the freedom to go to major professional conferences and the issues of childcare there. But then let's turn to your ASCO presentation, which really, I would say, was one of the most influential ones in terms of how people came away from the meeting, what they talked about, and potentially lingering impact, if not in changing clinical practice, but potentially in changing how we all interact at conferences. So, can you talk about the study, what that came from, and some of the key findings?
Well, I think the beginning of the story is that I started hearing how women were introduced by first name only at large conferences. I thought I was crazy, so I went around and I asked if my observation was true or not. And then I connected with Dr. No, and she's like, "Yes, I heard that." So with this,
And so that's Miriam Knoll, the radiation oncologist. Yeah.
yes. So we decided to watch all videos or all presentations from ASCO 2017 and 2018. It was an amazing effort by great people that work with me. We watched 2,511 videos to see how women versus men were introduced at ASCO. Surprisingly, we found that women were more likely to be introduced by first name compared to men, and they were less likely to be introduced by their professional title. Take into account that all the speakers had a doctoral degree. So that was a very sad finding to us, that despite all having the same training, unconscious bias still gets there when our women are being introduced. And many people ask us, why is this important? And one of the things is that in linguistics, if you're introduced by your professional title, the people are more likely to pay attention to you. I'm a Twitter user. So when you're in ASCO, you're in Twitter, you're in texting your friends, you're trying to check Epic for a little bit. So trying to get the audience attention is very important. So if I'm introduced as NJ instead of Dr. Duma, people are less likely to pay attention to me or believe my data. And lastly, I think it was very important to find this out because role modeling is so important. We need to make sure that the younger generation can see who they can follow or who are potential mentors. So if this woman is introduced by their professional title, that young woman can say, oh, I can be like her, or I want to connect with her. So it was surprising results of so many introductions. We included 781.
And your key findings were that there were major disparities in how men introduced women. And that was really the only group that this showed for, correct?
Yeah, so when we divided the introducers, we noticed that the male introducers were most likely to introduce the woman by first name only, and they were also less likely to introduce a woman by their professional title. And on the other hand, we also observed that women introduce other women by first name, but it was less likely. The percentages were significantly lower.
How was this work perceived overall? I know it generated a lot of attention, and I think a lot of it positive, but I have heard that it touched some nerves and people were sometimes hostile to it and sometimes hostile to you. Can you talk a bit about that?
Yeah, I think the difference with this study is that it touched a personal level. Like most of the research we do is about how healthcare systems work, about the new drug. But this study touched about how I introduce my friend, how I introduce my colleague. And we were not expecting some of the feedback, unsolicited feedback we received. There's some public stuff in Twitter, but we received direct messages. Some people direct email us about how we were cherry picking the data and quoting and how this was going to divide the society. And our goal was not to divide a group of men versus women, but that if we were in this together and we all train the same, then we hope that we all are introduced the same. So that was new to me, Jack, to get that type of feedback. I wasn't used to it. But I have the Wolfpack to protect me and to, when some of the things came out, many people are like, well, the data hasn't even presented yet. So it was great to have the Wolfpack to be there to help me. And I also called some of the people that email me, Jack, because some of them have very valid concerns. I talked with somebody who's in his 60s, and he came from a very good place. He was worried that this type of research, we make things like back in the day when he was a resident. So then we discussed, and he actually helped me with my future project. Like he provides some feedback. So I think some of the exchange was good to make us all grow, but that was unique.
Yeah, and it certainly was a turning point in your career. I think that you're going to have a lot more opportunity and real command as somebody speaking on and researching this topic. Can you talk about what you see as some of the implications that you hope or expect to come from this? I think that many people, I hope most people, will be far more sensitive to this now that it's been called to our attention when, as you noted, this is not a deliberate slight, but a bias that people carry. But beyond being at ASCO or another professional society and introducing people, do you anticipate this potentially bleeding over into other behavioral changes that are going to be constructive to reduce gender bias?
I think something that helps is it keep or women power. And I have noticed now, and some people message me or we see it in social media, that women know this data was there. It is objective data. So now when they're introduced in the inappropriate way, they feel more comfortable correcting it. So I think that's also very important, that if you're able to correct it right in the moment, the behavior can be learned better. So I have heard how people say, like, thank you, I am Jenny, but I'm also Dr. So-and-so. So I think power to or women in medicine has been a great result of this study. And we're also hoping to move forward in other areas and trying to understand what are obstacles to get some initiatives. ASCO has been very responsive about working things up for next year. And I think that's a big step when the society that was studied is willing to make changes right away.
And takes it constructively rather than defensively.
They're great. And Dr. Powell, who's the upcoming education meeting chair, she is working with us to make sure we offer instructions, because most of the introducers were not given instructions how to present somebody, how to introduce someone. So giving some rules or using professional title can make a big difference.
Let's turn to your next chapter. You have just moved to Madison to work at the University of Wisconsin in thoracic oncology. I reviewed your past publications, and they're pretty diverse in terms of the range of cancer types that you've studied. When did you ultimately focus on thoracic oncology, and what attracts you to that field?
I fall in love with the patients. I know I wanted to do health disparities research in early therapeutics, but knowing what many of the patients with lung cancer have to face and just falling in love with them, having a connection that I can sometimes explain, make me decide for thoracic oncology. And I decided early on during my fellowship. And I think mentors also shape who you are. I have great mentors, including Alex Ajay was my mentor during fellowship. So you want to work with the population that you know, that you love, and that you can hope to make a difference. And that's what my women and men with lung cancer are to me.
What attracted you to the University of Wisconsin?
Well, as I said before, it was the cheese and the beer. Well,
Right.
after all, beer got me a husband. But it was the people. Working with Dr. Leal, Dr. Trainer, and Dr. Campbell, they're wonderful. They make me feel like I belong here since day one. Since I have dinner with them, the faculty invitation dinner, I felt very comfortable. And I also like the city. So Madison is very unique, Jack. It's like a little liberal bubble in the Midwest. So it is the lakes and the people, and it has many quirky shops that I remember from Seattle. So it felt like a Seattle before Amazon, if I can say that right.
Uh-huh. Well, it's a very dynamic college town, so that's great. You're going to be dealing with winter, got to be honest. Having grown up in Cleveland, I think it's a lateral move weather-wise, maybe a little better, but it's not going to feel like Venezuela, I'm sure.
They keep saying it's 10 degrees warmer than Rochester, and I hope that is true.
Okay, very good. Now, one thing that people who are successful in research and publishing may have in their careers, and I think you're experiencing or may soon experience earlier than many, is success in many facets of your life and career. And you have your personal life, potentially family life, and also career interests ranging from gender inequality and bias and Latin American community issues and thoracic oncology. Are you concerned about or thinking about if you have to choose where to focus your time, or for now, are you hopeful that you'll be able to continue to follow all of these channels and be able to pursue all of these and perhaps integrate them later?
I think that question is like when you ask my grandma which kid she loves more. It's like very hard to find out which of your kids do you like more? And my grandma always says, I like one more one day and I like one more the other day, but I love them all. And I thought it was always a political correct answer to what she wanted it that day. So it is true. I think some things can be, associated like Latinas and gender equity and lung cancer. So I think the common theme would be woman, if I call it an umbrella. So I really have a lot of interest in women with lung cancer and their unique challenges. And soon to do a study about vaginal dryness and TKIs, for example. But I don't really know how to combine them all. So I'm learning, and I hope in the next 2 years we find a way to delegate and a way to like put them together. I just love them all, and it is a new challenge. And to be honest with you, Jack.
Well, and also kind of a champagne problem to have so many areas of success that you may have to choose how to prune that tree. It's a good problem.
I would go with that. I think I have a very whiteboard that I go for my new office. So I start next Monday. That's my first day as a grown up. So I'm hoping to put all the projects there and see if I look at that board every day for many more months, it would come together. So,
well, and I also want to thank you. We really didn't have opportunity to talk about your commitment to patient education, especially in the Latin American community, but you have already done great things with the cancer education nonprofit that I founded, GRACE, Global Resource for Advancing Cancer Education. And you're actually one of our first patient education ambassadors in a new program for the year. I think that's a wonderful commitment on top of your already busy array of activities. But it's great for all of the oncology community. It's good for the patients. The work you're doing is, I think, providing important insights for how we interact based on gender. And even when that is uncomfortable, it's important. And of course, I look forward to all that you're going to contribute in the field of thoracic oncology. So I am hopeful that we have the opportunity to have further discussions about all that you're doing as your career evolves.
Thank you, Jack, and I hope to see you in Barcelona.
I look forward to that. Thanks so much. Thanks for listening. The West Wind Podcast is a Beacon Medical Interchange production with sound engineering and distribution by Mark Lindsay of Talking Speaker. We hope you'll be motivated to subscribe, whether at BeaconMedIC.com, through iTunes, or through another podcast service. Please also rate it, and I hope you'll be inclined to tell friends and colleagues in real life and on social media. We're always happy to get your suggestions and other input at westwindpodcast@gmail.com. Talk to you again soon.